pediatric, including nutrition, including thyroid, breast. So we start by trauma. We have about 100 questions. We take about half of them, about 50 questions today, and the next Tuesday we take the other. So Dr. Mardina, you can start.
Yeah, Prof. A 28-year-old man is in the surgical intensive care unit. He suffered a flail chest injury several hours earlier and he was intubated and ventilated. Over the past few minutes, he has become increasingly hypoxic and now needs increased ventilation pressure. The trachea is shifted to the other side. Which one of the following is the most likely diagnosis? D. Tension pneumothorax.
Yeah, this is sometimes the patient on ventilator can be have tension pneumothorax due to high pressure, especially in positive end expiratory pressure or B ventilation. Of course, the diagnostic of tension pneumo is shifting of trachea to other side. If the patient is medical and have rupture pulley, usually rupture pulley can cause tension, can cause pneumothorax, but not tension. We call this simple pneumothorax. Of course, nowadays we insert the chest tube and the decompression needle in the fifth intercostal space anterior to mid-axillary line, not like before, which is inserted in the mid-clavicular second intercostal space. So now they change the policy. Okay, next question.
A 28-year-old man is involved in a road traffic accident and sustained a flail chest injury. On arrival in the emergency department, he is hypotensive. On examination, he has an elevated jugular venous pulse and auscultation of the heart reveals muffled heart sounds. What is the most likely diagnosis? C. Cardiac tamponade.
Yeah, of course, cardiac tamponade, we have congested neck vein. Congested neck vein, it means that elevated jugular venous pulse. Patient have weak or muffled heart sound. This is hypotension also. What's this triad called?
A back striate.
Beck's triad. So we have triad of hypotension, congested neck veins, and weak or muffled heart sound. Okay. All right. Next question.
Uh, Prof, sorry.
Yeah.
Have you shared the questions, the script?
Yes, I share it. Is something disappear or what?
Yeah, it disappear.
Okay. So 3 now,
Okay.
you see it?
Yeah, 3. Okay. Yeah, now I see.
Yes,
A
can.
27-year-old man is involved in a road traffic accident. He is seen in the emergency department with chest pain. Clinical examination are essentially unremarkable and he is discharged. He subsequently is found dead at home. On review of his previous chest x-ray, there is a widening in the mediastinum. What is the most likely underlying injury? B. Traumatic aortic disruption.
Yeah, usually widening of mediastinum, if you found after trauma, it is traumatic aortic disruption. Of course, it is different from, of course, this is related to trauma, but sometimes you can find widening of mediastinum if patient have thymus gland tumor or lymphoma, mediastinal lymph node. Okay, this is a picture of widening mediastinum. Okay, next question.
A 22-year-old man is brought to the emergency department. He was found trapped under a building collapse, lying unconscious on his right arm. His right arm is mottled in color and swollen, and his hand is stiff and has no sensation. What substance is most likely to be present in increased quantities in the urine? C. Myoglobin.
Yeah, what is this condition called?
Um,
It is crash syndrome or
Crush.
rhabdomyolysis. If you have collapsed the building, it is common in some area have earthquakes like Indonesia. So if you collapse the building, affected your hand or your leg, is difficult to come out or to evacuate it from the area. So injury of the muscles, the myoglobin is secreted in the circulation or distributed in the circulation, and they can cause injury to the kidney. And this is syndrome is called rhabdomyolysis, or means that the myoglobin can be block the kidney and the patient have acute kidney injury. It is curable, by the way, but need to deliver the patient or evacuate it from the collapsed building as soon as possible. Okay, next question.
A 23-year-old man sustains a severe facial fracture and reconstruction is planned. Which of the following investigation will facilitate pre-operative planning? D. CT of the head.
Yes, usually you have something called Lefort classification, Lefort 1, 2, 3. 1 if affected the maxilla. 2 is affected up till the goma. 3 is affected the orbit and the upper part. It is important to do CT for the head. But if it is only in the mandible, we have something called panoramic X-ray. Now they can do by CT also. It is like you see all the mandible area in one film. It's called panoramic X-ray. But here we speak about the skull or facial fractures, so it is CT. This is a picture by CT also. It is diagrammatic, but you see like this. Of course, this fixation done by maxillofacial surgeon, not by general surgeon. Okay, after trauma or related to trauma, we have neurosurgery. And in neurosurgery, usually ask you about Glasgow Coma Scale. So it is important to know Glasgow Coma Scale. Just for revision, Glasgow Coma Scale is something in the eye out of 4. In the verbal is 5, and the motor is 6, so the total is 15. If it is below 8, so it is indication to put endotracheal tube. Okay, so we back to you again, so you can start.
A 20-year-old man is hit over the head with a mallet. On arrival in the accident and emergency department, he opens his eye to pain and groans or make incomprehensible sound.
Yeah, can make it one by one. Is open his eye to pain and groan, so it is E.
Is E2.
E2. After that, make incomprehensive sound, so it is
V2.
V2. 2, yes, sound, comprehensive sound, V2. And after that, motor and on application of painful stimuli of his hand, he extend the arm to elbow, so extensor. So it is
M2.
M2. Okay, so E2, so V2, M2. So the total is
6.
6. Okay, good. The same also, it is important to know that in exam, usually the same topic come after each other. So if you don't know the topics well, don't be depressed. Okay. Next one. It is another question. Yes.
A 20-year-old man, after excessive alcohol intake, falls over and bangs his head. On arrival in the emergency department, he opens his eyes in response to speech. If response to speech is E3.
E3, yes.
Can speak although he is disoriented. Can speak, but although he's disoriented is...
Can speak, so it is V.
Is disoriented is V3.
Can be 3, can be 4, can be 4.
Can 3 or 4.
Okay, so 4, I just confused, can be 4. Okay, what about the motor? And he obey motor command.
So it's M6.
M6, okay. So now we have E3, V4, M6. So it is 3,
13.
4, 6, so 13. So the answer is 13. Okay. Next question, still in Glasgow scale.
A 20-year-old man is hit over the head with an iron bar. On arrival in the emergency department, he opens his eye in response to pain, which is E2. His only verbal response in the form of groans and grunts, V2.
Yes.
He flexes his forearm away from the painful stimulus, which is flexion, M3.
3. Okay, so E2, V2, M3. So 2, 2, 3. So the answer is 7.
7, yeah.
Okay. So as you see, they bring 3 questions in the same topic. So it is important, one of the policy of exam. So if you don't know these topics, no problem, but don't be depressed because they affect your performance in the other question. Okay, next is not Glasgow scale. Okay, go on.
Sorry, Prof. For the motor component, if you go back to the Glasgow picture, the motor, if the normal flexion and abnormal flexion, how do you want to differentiate if they
No, it is
give the scenario?
difficult. It is difficult.
Yeah,
It's difficult to
correct.
differentiate, but usually we don't, for example, here we have seven, we don't have eight.
Okay.
Okay, because we have a discussion about it. I write in my notes, so we have abnormal or abnormal fracture. So if we make it three, if we make it four, you don't found eight here. Okay,
Okay.
so don't worry.
Uh, okay, understood.
Okay. By the way, the exam is run many times in the year and for long time. So all these question or topics, even my question is validated many times. So they usually we
Mm,
know this minor thing. Okay, but
mm.
good observation, doctor. All right. Okay.
The question 9. A 32-year-old man is involved in a motorcycle accident and sustains a close unstable spiral tibial fracture. This is managed with an intramedullary nail. On return to the ward, he is noted to have increasing pain in the limb, and on examination, the limb is swollen and tender with pain on passive stretching of the toes. Which one of the following is the most likely diagnosis? C.
Mm.
Compartment syndrome.
Yeah, it is important to know that usually compartment syndrome occur after open surgery or intramedullary nail because it is for the, you know, that usually orthopedic have yeah, aggressive manipulation. So can be injured, can be cause bleeding. So if the patient have this, so it is can be compartment syndrome and fasciotomy must be indicated or sometimes as you see letters, if you have plate and screw, so it's better to explore the wound because maybe during putting the plate or screws, they can injure one of big arteries. Okay, last question for you, and it's little difficult.
A 33-year-old lady develops a thunderclap headache and collapses. A CT scan showed that she has a subarachnoid hemorrhage. She currently has no evidence of raised intracranial pressure. Which of the following drugs should be administered? Uh, my answer is D, nimodipine.
Yeah, it is mentioned that he's not rise intracranial pressure
I see.
because usually we give mannitol, we give diuretic if the patient have increased intracranial pressure, but here we give this nimodipine, which is a calcium channel blocker. It reduces vasospasm and improves the outcome.
Mm,
Okay, so it is important because sometimes, suppose in exam, right, they have evidence of the increased intracranial pressure. So I think mannitol will be the correct answer.
mm.
Okay, thank
Okay.
you. So I think we have Dr. Hong. Are you ready? You can read or
So,
okay. So welcome, Dr. Hong. We can start from 11.
a 28-year-old woman collapses and found to be deeply comatose with a GCS of 3. She is admitted to the hospital, intubated and ventilated. A CT scan shows an extensive subarachnoid hemorrhage, infarction in the hypothalamic and hypothalamic infundibulum or pituitary stalk region. A urinary catheter is inserted. What is the
Yeah,
amount of urine output that will be expected?
this is question have a trick. It is one of the difficult question. What you think? Why we mention hypothalamic infundibulum or pituitary stalk? What we need to tell you? By the way, if any patient have a trauma or hemorrhage, he have hypotension and concentrated urine and low urine. This is the typical in the most of the cases. But here we insisted to say have something in hypothalamic and pituitary stalk or the area between hypothalamus and the pituitary. What we think that we are need you to answer. What you think? What we need to ask? Dr.
Mm,
Mardina, I think is anyone sees this question before he can maybe have the idea. What you
Yeah.
think? Yes.
When they mention about the pituitary stalk, it wants to mention that it secretes the hormone ADH. So in this case, when they have a
Yeah.
trauma, can cause like a diabetes
All right. Okay.
insipidus. Yeah.
So you know that in all head injury have two exception. So usually the patient have hemorrhage, have bleeding. and they can be have hypotension, but in the head injury, due to cushion reflex, they can have also hypertension. And also, although it is very rare, sometimes in the brain hemorrhage due to trauma is affected the area between pituitary and the hypothalamus, so affect the antidiuretic hormone. So the patient is mimic diabetes insipidus. Who, if you have diabetes insipidus, instead of we have concentrated urine and oliguria, which is common in the shock, so we have more urine and diluted urine. Okay, you got the point, Dr. Hong?
Yes.
You hear about this before or not, by the way?
Oh no, never. Just
Okay, so it is rare, but actually it is appears that patient have subarachnoid, not extradural, not subdural, and affect the pituitary hypothalamic. So what you choose to mimic diabetes insipidus?
30 ml diluted urine per hour.
Yeah, 300 diluted urine. So the urine become diluted.
I answered.
And the amount is more. So this is exception. If you see the question straightforward, you say a patient have hemorrhage, have trauma, so must be have concentrated urine and have little amount of urine. Okay, like first one. But actually, because it is affected the pituitary hypothalamic axis, so it is different, totally different. Okay, so it is mimic diabetes insipidus. I write this here. I write the reference because many of the students for this question, for many years, answer it the first one. Small amount, concentrated urine. And they can be corrected if I remove this axis and all this and say, suppose they have extradural hemorrhage, so what you expect is the urine. So the answer become A. But for this question, the answer is A. Okay, so it is important to know that usually in exam you see the same question with little change and the answer become different. All right, this reference if you are interested to see. Okay, go to the next question.
A 21-year-old man is involved in a road traffic accident. After a transient period of concussion, he is found to have a GCS of 15 by the paramedics. On arrival at the hospital, he is monitored in the side room of the emergency department. When he is next observed, he noted to have a GCS of only 3 and a dilated fixed right pupil. So which of the processes below best accounts for this deterioration? Subdural hemorrhage.
No, actually, subdural hemorrhage not occur in young people, occur in older people because of atrophy of the brain. But this patient is deteriorated. He most probably have extradural hemorrhage, is not written here, have extradural in the right side because the pupil dilated in the same side. But because of neglected or rapid progress of the condition, so they have herniation of the brain. This herniation of the lower part of the brain, we call it transtentorial herniation or brainstem herniation, and it is the common cause of death in extradural hemorrhage if patient not observed, not noticed at the time. I think the mistake here, the patient Gras coma scale is full, is good. So they don't think that they have head injury. But usually we expected head injury if the patient, for example, don't wear a seat belt or motorcycle, don't wear a helmet. So you can, from the scenario of event, you can diagnose it. So the answer here is transtentorial herniation. Okay, next one.
A 70-year-old alcoholic man attends the emergency department. On examination, he has no evidence of involvement in recent trauma, and a skull X-ray fails to show any evidence of skull fracture. He is admitted, and 12 hours following the admission, he developed a sudden onset headache and becomes comatose and dies. Which one of the following is the most likely to the underlying diagnosis?
Okay.
Acute
No,
subdural.
it is not common, but usually patient in old age due to mild trauma, he have subdural. But this patient have no trauma at all. So it is not subdural, not extradural. So sometimes due to severe hypertension, the patient develops subarachnoid hemorrhage. So this case of subarachnoid hemorrhage. Okay. If it is young baby, can be intraventricular hemorrhage. It's in baby. I think maybe next question or we have it before. So here the answer is extradural. Okay. Or any questions?
No.
Okay, next question.
A 65-year-old lady is admitted to have fallen down some stairs, sustaining a multiple rib fracture 36 hours previously. On examination, she is confused and agitated, and has clinical evidence of lateralizing sign. She deteriorates further and dies with no response to resuscitation. Which one of the following is the most likely the underlying diagnosis? Uh, Acute subdural hemorrhage.
Okay, it is correct. But because we have also debate by many students, if you Google in your computer, acute subdural hemorrhage occur within how many hours? And tell me the answer. I know the answer, but I just need to search for it. Okay, take your time if you are in computer. Anyone know the answer till he come?
Within
Here,
72.
Okay, all right, good. So it is acute subdural hemorrhage. Acute is within 72 hours. 72 hours means 3 days. It's still acute. Anyone, Dr. Mardina, you need to tell something, or Dr. Kashira?
just now I wanted to say minutes to 72 hours, 3 days.
Yeah, okay. So it is important because some students say, okay, 36 is difficult to be acute, but actually, by definition, acute subdural is from minutes till 72 hours till 3 days. After that, become chronic. Of course, the common is chronic, but within 72 hours within 3 days is still acute subdural hemorrhage. I just ask you to looking for it, just to remember, because maybe an exam become 40, become 50, become 70, so you still acute, not chronic. Okay, good. Next question is very common and have a lot of debate also.
A male infant is born at 28 weeks of gestation by emergency cesarean section. He is taken to the theater for a colostomy due to the imperforated anus. He initially seems to be progressing well. However, he begins to develop decerebrate posturing and becoming increasingly obtundant. Which one of the following is the most likely the underlying diagnosis? The intraventricular hemorrhage.
Okay, so although for me a general surgery, I don't know this, but actually, if you ask any pediatrician, one of the common deaths or cause of death in the premature baby, this is intraventricular hemorrhage. We don't clear know what is the cause, but because the patient have some anomaly, maybe some anomalies in the brain or something related to delivery, we don't know, but it is the common is intraventricular hemorrhage. Okay, after that, we have a group of questions speak about something called ASA or ASA scoring or anesthesia scoring. It is 1, 2, 3, 4, 5, sometimes 6 now because if the patient died. So 1 is normal, 2 is patient with mild systematic disease like hypertension and diabetes but is controlled. 3 is a patient with severe systematic disease like diabetes, hypertension, not controlled. 4, patient's severe systematic disease and constant threat in his life, so it is critical. And 5, it is a patient with severe systematic disease. There is constant threat in the life, and morbid means that this patient in the end stage, or what we call it, gasping. Of course, this is scored by American Society of Anesthesiologists is a scoring method to stratify the patient for physical status. So we start by first one.
A 66-year-old man is admitted following a collapse. He was waiting for a bus. Clinical examination confirms a ruptured abdominal aortic aneurysm. He is moribund and hypotensive. Which one of the following is the most appropriate ASA grade? Is a life-threatening, so it's a ASA 5.
5. So it is a 5. Okay. Morbid, rupture aortic, can be die. So it is 5. Next also ASA.
A
Okay.
23-year-old man with a 4 centimeter lipoma on his flank is due to have is removed as a day case. He is otherwise well. Which one of the following is the most appropriate ASA grade? For this one, not much. So this is ASA 1.
Asan, so young patient, lipoma is minor operation. Patient have no morbidity, nothing. He's young, so it is ASA 1. It's still in ASA. Okay.
72-year-old man is due to undergo a strangulated inguinal hernia. Repair as an emergency procedure. He suffers from COPD and has an exercise tolerance of 10 yards. He also has pitting edema in the thigh. Which one of the following is the most appropriate ASA grade? ASA 4.
Yeah, this is patient have many morbidity. First, strangulated hernia, not straightforward hernia. Have chronic obstructive pulmonary disease and exercise tolerance at 10 yards, so it is have dyspnea. Betting edema, so maybe have heart failure or something like that. So it is under the category 4, which is a patient with severe systematic disease, constant threatening his life. But of course, because this is strangulated, we will do the operation, maybe using spinal, even local, may be difficult for local, but at least the spinal. Okay, last one.
45-year-old man, patient with tachycardia, feverish, and hypotension on inotropic drugs. Which of the following condition is the most likely diagnosis? The septic shock.
Okay, so this is straightforward. Usually in exam, as we mentioned, some question is so easy. Some question is difficult. Some question you don't take a time to think. It is just a few minutes. And another question you take 2 minutes to think for it. So this is some sort of the compensation. Thank you, Dr. Hong. So I think we have now Dr. Jaya. So I just share with you the rest of the question. Yeah, I just share the question. In this group of the question or this type of the question, we start by surgical nutrition. Okay, surgical nutrition mean the nutrition post-operative or in preparation. Okay, the first question is very common to come in exam. Still have some debate, but we can solve it. Are you ready or is okay?
Yes.
Yes,
Good
okay, you
evening,
can read.
Prof.
Good evening. Hello.
A 72 years old man is due to undergo an esophagectomy for malignancy. His BMI is 17.5. What is the most appropriate immediate method of nutrition post-operatively? Feeding jejunostomy.
All right, it is feeding jejunostomy simple because after you remove the esophagus, what you put instead of esophagus? This segment of esophagus you removed, what you put in this space? If you remove 5 cm, 10 cm from esophagus, what we put instead?
Jejun.
No, we put the stomach up. We called it stomach up. If you put the stomach in the thorax, so it is no place for jejunostomy, no place for gastrostomy or pig and others. So the only solution is feeding jejunostomy. So one of the step of operation, just to take the jejunum outside. It is the same technique we make it in colostomy or ileostomy, and put a tube inside just for feeding. It's called feeding jejunostomy. It is very common question, and usually student answer it TBN, but actually it is feeding jejunostomy. Why? Because for many years we use TBN. But now they found that if the patient have a rest of the intestine for long time, till recovery happened, it have some sort of endotoxemic shock because the bacteria, which is a commensal inside the intestine, flare up and spread to circulation, cause endotoxemic shock. So nowadays in the surgical practice, they prefer early feeding of patient by enteral feeding to avoid this change in the bacteria, which is commensal bacteria, sometimes called Mycobacter or all this type of bacteria, which is benefit bacteria or beneficial bacteria, just to avoid endotoxemic shock. So this is why we start by jejunostomy feeding. Okay, next question.
A 28 years old man is comatose from head injuries and admitted to the neurosurgical ICU. He is recovering well and should be extubated soon. Which one of the following is the most appropriate method of nutrition? NG2.
Yeah, this patient is recover well, so maybe within 1 week become conscious. So we make nasogastric tube, all right. So suppose I mention this patient is in bad condition and suppose recovery maybe take months. So what is the methods of feeding?
PEG.
Yes, percutaneous endoscopic gastrostomy. So it is according if the patient in the improving condition, nasogastric tube. But if he will be comatose for months, so we don't do that. If comatose for long time, it's better to have percutaneous endoscopic gastrostomy because nasogastric tube sometimes can dislodge, sometimes it can cause aspiration, care may be difficult. So to avoid aspirated pneumonia and chest infection, so in the patient of long time of coma, percutaneous endoscopic gastrostomy. If patient easy or doing well, so can be nasogastric tube, oral tube. Okay, next question.
A 43-year-old man is recovering from a laparoscopic assisted low anterior resection with a loop ileostomy. What is the most appropriate method of nutrition on the third day post-op? Normal oral intake.
Yeah, normal. It is important to know because some students or some doctors do not understand this. Suppose you have left hemicolectomy and the patient have colostomy. And sometimes we afraid from anastomosis usually in surgery. But suppose this patient theoretically after he recover from anesthesia and tell you, doctor, can I eat or drink? Suppose he eating now, this food is not come through the anastomosis because the colostomy is before it. The colostomy is proximal. So we don't afraid from any anastomosis. So the patient, if have colonic surgery with covering colostomy, he can eat as early as possible, no problem. Okay, once they have intestinal movement is okay, he is recovered, he's conscious, so he can eat, no problem. Okay, so normal oral intake. Next question.
A 23-year-old man is recovering from an appendectomy for a perforated appendix, and he is now in the ward. However, his urine output is decreased, and he has been vomiting. Which of the following intravenous fluid should be initially administered pending analysis of his urea and electrolyte level? Harmon solution, linga lactate.
Yeah. Okay, so it is means that this patient have vomiting. If patient have vomiting or diarrhea, he lost a lot of potassium. So we need to give him solution rich in potassium. Ringal lactate is the sodium chloride beside potassium. Other like salines and all this is not contain potassium. So this is we give him potassium reaching fluid. Okay, next question.
A 32-year-old man present to the acute surgical unit with acute pancreatitis. He suddenly became dyspnea and his saturation are 89% on air. A chest X-ray show bilateral pulmonary infiltrates. His CVP pressure is 10. What is the most likely diagnosis? ARDS.
Yeah, one of the complication of the acute pancreatitis have two complications serious. One is ARDS, adult respiratory distress syndrome. Actually, till now we don't know the exact pathology for that. Some say maybe some pancreatic enzyme affects the lung. We don't know. The second serious condition can occur in acute pancreatitis is acute kidney injury, and the patient have some sort of renal failure, but it is reversible. Okay, next question.
And Prof, I
Maybe
have a question.
yes.
Regarding the ARDS, how we differentiate between the ARDS and the transfuse related lung injury? Because if the patient have the, for example, like the patient undergo a surgery with a multiple blood transfusion, and then post-op 6 hours, the chest X-ray show the bilateral pulmonary infiltrate with the oxygen saturation drop. How we differentiate between, is it because of the transfusion related or just ARDS?
No, transfusion it is the same. We can consider both as ARDS and give oxygen is the patient not response, so put in ventilator. So whatever the cause, it is from blood or it is from the pancreatitis, we put in the ventilator. So it is not much difference. So both are the same. Okay.
Oh, okay.
All right. Okay. Next
thank you.
question. Okay.
43-year-old man has symptoms of carcinoid syndrome. Which of the following is the most effective therapeutic agent in controlling the symptom? Octreotide.
Yeah, what carcinoid syndrome is occur in tip of appendix and sometimes in ileum. What is carcinoid secrete?
Serotonin.
Serotonin. So this is serotonin. This is in the here. So he secretes serotonin. But the antidote of serotonin, you can give octreotide or you can give ondosterone. But we give usually octreotide. He decreases the portal circulation or portal hypertension. What is the tumor marker for carcinoid syndrome? Or what is the end product of serotonin in urine?
Not sure.
No, serotonin is 5-hydroxytryptamine. The end product is 5-hydroxyindole acetic acid or 5 higher. We have 3 tumor marker in urine. One is the carcinoid syndrome, is called the 5-HIA, which is the end product of serotonin in urine. Second tumor marker in urine, it is the patient with multiple myeloma. They have what we call the Bence-Jones protein. The third tumor marker in the urine is the tumor marker from pheochromocytoma, and it is phenylmandelic acid or VMA in the urine. So only 3 tumor marker can appear in urine. Again, carcinoid tumor 5 higher, uh, multiple myeloma Bence-Jones protein, and pheochromocytoma VMA. Okay. Next question.
A 48-year-old man is recovering in HDU following major surgery. His pre-operative medication include an S inhibitor for blood pressure control. For the past 2 hours, he has been oligurid with a urine output of 10 ml per hour. What is the most appropriate management? Administer a fluid challenge.
Okay, so this patient have 10 milli per hour. It is important to know it is a normal urine can be 1 ml per kilogram body weight per hour. So this patient is adult, so can be 70 kilos, so he must be more than 17 milli per hour. So this is need to test what is the cause of that. So we have something called the fluid channel. What is fluid channel test?
Restrict the fluid.
No fluid, no fluid. What is written here? It is admission fluid challenge test is we give the patient 250 of the saline within 10 minutes and measure the CVP and the urine output. So this is indicate if this patient have dehydration or over infusion or normal. Okay, so it's called fluid challenge test. Okay, it's very important. You can read it, and very important is come regularly in our question. It's called the fluid channel test. Okay, it is done usually patient have central line. Okay, all right. Next question.
A 56-year-old lady presents with pathological fracture of the proximal femur. Which of the following primary site is the most likely source of her disease? Breast.
Okay, so is of course because this is a lady, and the most kidney tumor uterus is usually not spread, very rare to spread. Thyroid sometimes spread, but usually spread follicular thyroid carcinoma in the skull and the flat bone. So usually the breast can occur in vertebrae, can occur in long bone. Okay, next.
A 63-year-old man undergoes a laparotomy and small bowel resection. 12 hours post-operatively, he is noted to have decreased urine output. Which of the hormone listed below is most likely to be responsible? Vasopressin.
Okay, you mean antidiuretic hormone or vasopressin? Yes, this is the correct answer. All right. After that, we have some plastic and skin disease. Also, after that, we have skin manifestation of some medical disease. So we just have 2 questions here. You can start by wound management. Okay, you can start.
A 63-year-old male is gardening when he tripped and landed on a sheet. He sustained a deep laceration of his lateral thigh, which measured 3 cm in depth by 7 cm in length. It penetrates down to the bone, but no fracture is evident on X-ray. He presented to the hospital 9 hours after the injury. He has type 2 diabetes mellitus and is on prednisolone for rheumatic pain. Which one of the following is the most appropriate management? Delay primary closure.
Okay, so why delay? It is delay, yes, but why?
Because the wound might be contaminated and there is a high risk of infection, patient and
So
diabetes and steroid.
what is the maximum hour you don't do a suture?
6 hours.
6 hour. Okay, so if the patient come to you after 6 hour, it is not wise to just clean the wound and cover the wound by non-adherent dressing. Of course, we just make it clear because this patient have diabetes, have on the corticosteroid, so the possibility of infection is high, and he is presented late, so 9 hours, so it is for delay primary closure. Next question also have a lot of debate. Okay, you can read it.
A 71-year-old lady tripped over the floor, landing on her left shin. She sustained a large pretibial laceration of her leg, difficult to approximate. Which one of the following is the most appropriate management? Delay split thickness skin graft.
Delay. Okay, I just explain this because this is also have a lot of debate in all other centers. So why we say the pre-tibial or shin of tibia? Because shin of tibia, if you see the shin of tibia down, is the skin, then the bone, no muscle. When you put a graft or a skin flap, it depends on the blood supply from the underneath muscle. Now we don't have muscle. So in this situation, we just clean the wound. We need till a little granulation tissue is formed, and after that we make delay split thickness grafts. So not immediate at all, because if you make immediate, is not take, because skin grafting is don't take if you put in bone or put in tendon, because bone and the tendon and the ligament is not highly vascular, is less vascularity. So we just leave till happened till we have granulation tissue. I just put here and also put in the answer sheet what we call Denking classification. This Denking classification is only for tibia. So the skin of tibia, if this is just laceration, you can have a steer strip. Steer strip means sterile strip. It is just like a plaster to approximate. But if lacerated and the flap, just clean it and have hematoma and just put a steer strip. If it is loss of the skin and they need grafting, so you make a grafting, but it's better to be delay. If it is major, so you make debridement and the later you become a grafting. If you are in highly center of the plastic, like plastic surgery unit, they have something called gastrocnemius free flap. So they take part of gastrocnemius, rotate it and put it in this area and put the skin over. So the grafting is take a blood supply from the gastrocnemius. But this is only done in a specialized center for plastic. But if you speak about general surgery, so the answer usually it is delay split thickness graft, not immediate at all. Okay, thank you, Dr. Jaya. So, Dr. Kashira,
Yes,
you
Prof.
can, all right, you are welcome. So, this is your turn, question 31.
Okay, a 73-year-old lady present with also overlying medial malleolus. It is painless and been present for 4 months. She has edema of lower limbs and her ABPI measures 0.9. Which of the following is the most appropriate management? C. Compression bandage.
Yeah, what is your diagnosis? What this patient have?
Venous ulcer.
Venous ulcer, because in the gutter area, middle malleolus, ankle brachial index is 0.1, so it is not ischemia, so it is just venous ulcer. We make compression bandage. Usually we call it 4-layer bandage, and first layer must be non-adherent dressing. Okay. After that, we speak about how to take biopsy from skin or skin disease, and it is important to know it is depend on the it is query cancer or not cancer. Because this exam is a British exam, so they are interested by skin tumor. So usually if the tumor is malignant, we remove the tumor with safety margin at least half centimeter. So sometimes you have a tumor, we don't know it is benign or malignant, so just take biopsy. And if it is a cancer, so make a safety margin. If not a cancer, just remove it with little safety margin. So this is why it is important to know before you start it is benign or malignant, because most of the skin tumor occur in the face. In the face, we don't have much skin to move. So you need to be sure before you remove it is benign or malignant. Of course, we can take punch biopsy, the same for big tumor, or sometimes they put just a slide. You know, this slide, glass slide, they just make it like this. We call it shape biopsy. Like you make it moving, so they take some superficial cell. So it is different according to which site. Okay, so you see the title now or not?
Yes. 83-year-old lady present with multiple patches of pigmented irregular superficial lesion over the torso. They do not bleed but have become increasingly itchy. Which of the following is the most appropriate management? My answer is B, shave biopsy.
Yeah, is this is cancer or not cancer? What you think? It is multiple, usually cancer, not multiple. Although
Yeah.
irregular may be,
Yeah,
but usually melanomas and other is not multiple. And not bleed and touch. So usually bleed and touch is with a cancer. But this not bleed and touch. Whatever, we just take shape biopsy. Okay, next one.
65-year-old man present with long-standing 5 cm ulcerated area over the medial malleolus. Which of the following is the most appropriate diagnosis biopsy? My answer is A, punch biopsy.
Yeah, what you think is this long-standing ulcer over middle malleolus? It, it is started as venous ulcer, but if we stay long time, we called it squamous cell carcinoma, or usually we called it marjolin ulcer. So long-standing venous ulcer can be changed to be malignant. So this is why we take bunch biopsy. If it is a cancer, so we need to remove it with safety margin, at least half centimeter. So we take a big area, so maybe have a lot of loss of skin. Okay, we don't we don't choose wide excision of the 5 centimeter because wide excision mean you take more and there may be not a cancer, so you need to confirm it is a cancer. What is your question?
Why is not true cut biopsy?
No, true cut biopsy is done in liver or deep organ like breast, like liver, but this is in front of you. Just take a bunch from it just by scissor or by knife. You take just a small piece, maybe half centimeter. Throat cut is a gun. If you see the throat cut, it is like a big needle. You insert it inside the liver and back again. You can insert it inside the breast. A fine needle is not give you result. So we don't use throat cut in the skin because it is not in depth. Okay, clear?
Yes. Yes, thank you.
Okay, next one.
A 23-year-old lady presents with itchy, bleeding, pigmented lesion on her right thigh on top of the previous hairy nevus. Which of the following is the most appropriate management? My answer is C, excisional biopsy with safety margin.
Yeah, actually in the thigh, you still have a lot of skin, even if it is a small thigh, but you can make undermining and have a skin. It's not like a face. So if you remove it with safety margin, so it is will be okay. Okay, next question.
A 52-year-old white man presents with nodule in his chin. He is concerned about because it has grown extremely rapid over the preceding week. On examination, he has a swollen red dome-shaped lesion with a central defect that contains keratinous type material. Which of the following is the appropriate diagnosis? E. Keratoacanthoma.
Yeah, we have the picture here, and you can find keratin in the center. Of course, if we don't mention the patient nationality, so it is British. Okay, and this keratoconcyoma is not common here. It's common in British area, exposure to the sun and something. It is not precancerous, but it is mimic a cancer. Because it is not precancerous, not a cancer, you can just remove it without safety margin, without anything. Okay, next one.
68-year-old Austrian farmer presents with a skin lesion on his forehead. It has been present for past 6 months and has grown slightly in size during that time. On examination, he has ulcerated lesion with pearly white raised edges that measures 2 centimeters in diameter. Which of the following is the appropriate diagnosis? A. Squamous cell carcinoma.
No, I just a minute. First, this is old man is Australian farmer. So why we make farmer? Because farmer is exposed to the sun. And Australia, because Australia, New Zealand is a common in the people in Australia to have skin tumor, because actually the people in Australia now came from Europe, and the original people, or what we called it like orange asli here or Arbijan, is dark races. We have a clue here. It is ulcerated and barely white raised edge. So it is everted edge. Everted edge is characteristic of basal cell carcinoma, not squamous cell carcinoma. Squamous cell carcinoma can be ulcerated but not has this barely everted edge. Barely everted edge is pathogenic or pathognomonic, this picture, for basal cell carcinoma. Of course, both are the same, but basal cell from the basal layer and the squamous cell from the superficial layer. By the way, what is Poin's disease is carcinoma in situ, so you don't see it. It is microscopic diagnosis. Melanoma is melanoma. Actinic keratosis is some sort of sickness of the skin. So the answer here is the basal cell carcinoma. Okay.
Okay.
Next one.
34-year-old gardener presents with a lesion affecting the dorsum of his right hand. It has been present for past 10 days and occurred after he had been pruning rose bushes. On examination, he has a raised ulcerated lesion that bleeds easily on contact. Which of the following is the appropriate diagnosis? My answer is pyogenic granuloma.
Yeah, this is picture. If you have foreign body injury, something like from flowers or gardening, and followed by this granuloma, so what we called it biogenic granuloma. It is common also in the umbilicus. So some people say scratch umbilicus or something, or by foreign body. So usually it is initiated by irritation, usually by very tiny, like pen break or foreign material. Okay, so it is diagnostic. Of course, the problem is this is bleeding easy, and of course, cosmetic, so must be removed. Usually can remove it by cautery, diathermy, chemical diathermy, and after that healing can occur. All right, next one.
70-year-old British lady presents with several skin lesions that she described as unsightly. On examination, she has several raised lesions with greasy surface located over her trunk, with scattered keratin plaques located within them. Which of the following is the appropriate diagnosis? E. Seborrheic keratosis.
Yeah, so seborrheic keratosis occur after exposure to the sun, or usually old people, and they have this all over pigmentation. It is not precancerous, it's not dangerous, but because it is multiple, usually it is a cosmetic problem. So this is called seborrheic keratosis. Of course, we ask the patient don't expose much to the sun. He can have a hat, eyeglasses, all these just to have no more or not increase. Sometimes you can spray if it is one or two by cryo, what's called the cryotherapy, so they can remove it. Okay, next one.
28-year-old female presents with small nodule located on the back of her neck. It is accessed for cosmetic reasons, and the histology report states that the lesion consists of sebum-filled lesion surrounded by the outer root sheath of a hair follicle. Which of the following is the appropriate diagnosis? E. Epidermoid cyst or sebaceous cyst.
Okay, then actually this is in the back, have punctum. It is called sebaceous cyst or dermoid cyst. The correct name is epidermoid cyst because it is not arise from sebaceous gland like the people think. It is arise from structure around the hair follicle, including including sebaceous gland, and they're characterized by these black spots, so usually appear in white rhesus and called sebaceous cyst and contain sebum. Sebum is like white material. It is like cheese or something like that. It's not like pus. And actually, the term cyst here is incorrect because cyst is cavity lining by epithelium, which is correct definition. But usually the students think that the cyst must be cystic and contain the fluid, and special cyst not contain fluid. So the correct name is still epidermoid cyst. We still use sebaceous cyst. Okay, next question.
21-year-old lady presents with a small nodule on the posterior aspect of her right calf. It has been present at the site for the past 6 months after an insect bite. The overlying skin is faintly pigmented. Which of the following is appropriate diagnosis? E. Capillary cavernous hemangioma.
No, this is okay. I tell you, this is common if you go to area and you have insect bite. If you have insect bite, so this insect bite makes the lesion like this. So this is reaction. This is reaction is not. You mentioned capillary cavernous hemangioma is something congenital. It is not due to trauma. It is look like this, but maybe more red. This is brown. This is called dermofibroma. Okay, hemangioma not developed by insect bite. You got the point?
Yeah.
But if I say this patient is born by this skin lesion, like red lesion in the face, so it is capillary or cavernous hemangioma. It is hemangioma. It is very common. You can see in some people they have patch in his face or abdomen or whatever. We called it hemangioma. Okay, thank you, Kashira.
Thank you, Prof.
So, Dr. Mardina, we are back to you again.
Okay, Prof.
Okay, you are welcome.
A 22-year-old man presents with an infected sebaceous epidermoid cyst. The cyst itself is swollen, discharging pus, and has some surrounding erythema. What is the most appropriate surgery for the infected cyst? My answer is C. IND with excision of the cyst wall and packing of the defect, suturization.
Yeah, so incision drainage, it is important in the sebaceous cyst or epidermoid cyst. You need to excise, you need to creating the area just to avoid local recurrence because this is if incomplete excision, it is recurrent. Okay. After that, we have a skin manifestation of disease. Most of this disease is rare in Malaysia, and the most of this disease you can see in UK, like celiac disease, like Crohn's disease, like of course the cancer is here. So it is important just to have an idea about this because, as we mentioned before, it is a British exam. You can start by first one.
A 22-year-old man is investigated for weight loss. He was diagnosed before as having gluten-sensitive enteropathy, celiac disease. Duodenal biopsy taken as part of his investigation shows total villus atrophy and lymphocytic infiltrate. He has a skin lesion with small itchy papules. Which one of the following skin disease is associated with the condition? C. Dermatitis herpetiformis.
Yeah, this is skin lesion can occur in celiac disease, which is rare, and we call it dermatitis herpetiformis. Okay, just to know it, don't any detail because celiac disease I think is very rare also. Okay, next one.
A 72-year-old man is investigated for weight loss and painless obstructive jaundice. On examination, he is deeply jaundiced and cachectic. He also has a dark velvety lesion in his axilla, body folds, and creases. Which one of the following skin diseases is associated with this condition? D. Acanthosis nigricans.
Yeah, Acanthosis nigricans, it is not skin disease. It is just the like something like paraneoplastic or skin manifestation of the cancer. Of course, we don't see this except in white rhesus, especially if it's so white. So in some cancers, GIT cancers, you can find this Acanthosis nigricans. Nigricans mean nigric, mean black color. Okay. All right. Thank you, Dr. Martini. We still have one. Okay, go on. 4-4.
Uh,
Okay.
a 32-year-old man with long-standing Crohn's disease. Which one of the following skin disease is associated with this condition? Pyoderma gangrenosum.
Yeah, this is biodermal. Okay, thank you. So I think for all these three diseases, this disease is not common. Disease common in UK, celiac disease. So we have this dermatitis herpes. Of course, nigrocanis albicans, acanthosis nigrocanis is in any tumor, may be found here, but Crohn's, they have also bioderma granulosum. Okay, so just know the names, don't need to know much detail. Okay, Dr. Hong, thank you, Dr. Martini. Dr. Hong, we have a thyroid.
All right.
This thyroid here is different. It is important to know that in exam will give you the normal value. Okay, and here it is a surgery. So we speak about condition in surgery like hyperthyroid or complication related to thyroid. Okay, so first question, slowly.
All right. Uh, 33-year-old lady attends the clinic with a 3-month history of palpitation and irritability. Her lab investigation are thyroid function test, which is a T440.
Yeah, it is
Is
high, so it is
high.
high T4. Okay,
Yeah, TSH is low,
low.
0.1. Free T3 is 25, which is elevated.
Yes,
PTH is normal, 10.
yes,
So what is the most likely diagnosis? So
yeah.
hyperthyroidism.
So it is hyperthyroidism. Okay, all right. Of course, we speak about thyroid. If you see the condition is mainly thyroid, so it is not parathyroid at all. Next question.
A 52-year-old woman present with palpitation. She's found to have atrial fibrillation. Her blood result reveal a T4 level of 30, which is elevated. TSH of 0.01, which is less than
Okay,
normal.
low you can found from previous one. So
Yeah.
it is okay. It is more than less than. So it is low.
Yeah.
Okay.
So which one of the following is the likely diagnosis? So it's a thyrotoxicosis.
Yes, okay, it is thyrotoxicosis. All right. Next one.
A 42-year-old woman present with a goiter. On examination, the thyroid feels lumpy. Blood result reveal a TSH of 12. That T4 is 2. Anti-thyroid peroxidase antibody are high. So his TSH is high. T4 is low. So positive.
No, no. The clue here is the anti-thyroid peroxidase is high.
Yeah.
Forget the thyroid hormone and TSH. So this patient have a swelling. Most probably it is painful, and this swelling is cause anti-thyroid peroxidase antibodies is high. So which disease of this list can cause antibodies high?
Hashimoto thyroiditis.
Hashimoto thyroiditis usually have painful thyroid swelling,
Mm.
and usually it is, if not treated, what happened?
It can become multinodular goiter.
No, no, multinodular goiter is easy. It's something serious. This Hashimoto thyroiditis can be complicated to be non-Hodgkin lymphoma. Okay, so lymphoma we don't consider as one of the thyroid tumor because it's not occur from thyroid proper, but you must be have Hashimoto thyroiditis to be followed by non-Hodgkin lymphoma. I just add on examination, the thyroid is feel lumpy and painful. Okay, and painful because this is character to have painful. All right. So it is very rare. Hashimoto is rare. So lymphoma in the thyroid is also rare. Okay. Next question.
A 55-year-old man been in the ICU for many months after an open aortic surgery. He is maintained on total parenteral nutrition. Clinically, he is euthyroid, but his thyroid function test reveal on a low TSH and low T4. The
So
sick
this
euthyroid.
patient is euthyroid. Yes, it is sick euthyroid syndrome. But sometimes the patient is longer recumbency in ICU due to electrolyte and the fluid and all this. So they have some sort of the disturbance thyroid function, but it's still in the normal thyroid. So it is euthyroid. So we called it sick euthyroid syndrome. Okay, last one.
A 29-year-old female undergoes a subtotal thyroidectomy 5 days post-operative. The wound becomes erythematous discharge pus. What is the most likely causative organism? Staphylococcus aureus.
Okay, so this is easy question, but don't say you have a trick or taken this question. Any surgery done in the body, you have skin commensals, you have skin infections, so common it is staph. Is nothing specific to the thyroid. Although thyroid is clean operation, the rate of infection is very minimal, maybe less than 5%, but sometimes if occur, it is usually due to staph aureus. Okay, so we finish for today. I meet you next Tuesday. I will send the answer today. I will send you the link for Tuesday, and will be the same time, 8 o'clock local time in Malaysia. Okay. Any question, by the way? Okay. It is important to have everyday study. If you enter the exam,